Okay, so thank you, Shia and Jai, for introduction. So I'm Supanath from Division of Epidemiology, Department of Disease Control, Thailand Ministry of Public Health, together with Dr. Vishan and Supansa. So today we would like to present digital disease surveillance and its application in Thailand. So first, we will start with the structure of the Ministry of Public Health in Thailand. Uh, One moment. Okay, so for our organization, we have hierarchical structure starting from central level into sub-district level. In each level, we have different organization with some connection into between the level. And then for surveillance, investigation, and response network, we have different unit and different team in for the surveillance and for the investigation and response. For disease control system, we have multiple pillars for disease control and excellence center. In those nine pillars, we use information technology is as in infrastructure. For today, we will focus on how we use information technology to improve surveillance and emergency operation center. For surveillance system, we starting it from since 1970. We starting from using the paper to make the surveillance using the telephone together with the letter. After that, 2006, we changed it into email with database file, but they still have some delay. So during COVID-19, we faced with that problem, so we changed completely into API, and then this saved us at least 2 weeks. The data is almost real time. So this diagram show how the data were sent starting from health facility. We use API to extract data from hospital information system directly. We use data standardization like what we call 40T files in Thailand. These are used primarily for reimbursement. And then we use medical terminology, including ICD-10 to extract that data. And then we have some data cleansing algorithm, and then we send those data into digital disease surveillance or DDS on cloud. And then after that, we create the web application called the 506 portal, where some hospital that they cannot send API, they can key in or make some edition, or they can view and download those individual data. And then we integrate that with syndromic surveillance and sentinel surveillance data. And then the other data set that we use is like data from event-based surveillance that we include notification from setting-based like school or factories or maybe community that they send some notification if they found some outbreak into local health facility or to the village health volunteer. And then this data sent to the event-based system and then join together with the data from hospital. This shows this data structure of the DDS. We have relational relationship between them, like the the person table, the hospital table, the epidemic table, the laboratory table, and the vaccine table. And then after we have some data, we create the monitoring system to identify the coverage and the timeliness of the data. So this shows the data in the hospital level, like including public and private hospital. We have 99.5% coverage. So almost 1,400 hospitals send data to us. And then right now we have around 6 million records reported into our system with 85 or 87% timeliness within like reporting within 7 days. And then these show all healthcare facility, not only hospital, but including some kind of primary care unit or maybe sub-district hospital. We have almost 12,000 units, and then the coverage is now almost 96%. And then now we have like data collection in our pipeline. but we need to do something else with our data that we collected. So we're thinking about how can we do data analysis to see the distribution or magnitude of those data. And then we're thinking about how can we interpret that data, what in hypothesis can we detect some trend or some abnormality. So this let us go back to the user. What do they need? How do they actually use those data? So actually, sometimes I just thinking that the technology is the problem, but human is the solution. Let's say if we build some thing like we build a path for some people, and then we decide like it should be really strong, really safe, go in the direction, and then you can go this direction. But it's not what the user actually needs. There is some path that really short and then they can just go stay there. So they create some their own experience. So this shows if you don't talk to the user, you are a developer and you just design anything that you want, but you don't use it by yourself. Maybe it might not meet the need of the user and they create their own experience. Yep, I will send this to Kun Supansa to explain more how we did that.
For design thinking, we apply design thinking to understand how users use the data from our system. The process has several steps. The first step is empathize. We go to the field, interview users, and see how they use the data in their daily work. The second step is define. We identify the problem and pain point that users face. The next step is ideate. We generate ideas to solve this problem. The fourth step is prototype. We create a model of solution so user can test it and give feedback. Finally, the fifth step is test. We let user try the prototype in real situation, collect their feedback, and refine the solution. During the empathize phase, we engage with various types of users, including executive, epidemiology staff, and healthcare workers, across multiple levels, such as national, provincial, and facility level staff. After talking with users, we identify around 10 key needs for the system, such as describing the disease situation, identifying priority disease, conducting early warning and alert system, supporting outbreak investigation and emergency response, verifying data coverage and timeliness, and communicating risk to the public. Here is an example of dashboard used to rank priority disease. User can apply filter to select the disease group, province, age group, and nationality they are interested in. They can then choose how they want to rank the disease, such as total patient, death, or mortality rate. By clicking on the column, the dashboard automatically sorts the disease, placing the highest value at the top. This dashboard tracks weekly change in patient number for each disease, showing increase or decrease from the previous week. After reviewing the disease ranking dashboard, we can use the disease situation dashboard to explore specific disease such as influenza. The green box shows the number of patients and the black box shows the number of deaths broken down by area in a table. The line chart below shows the weekly trend of patients compared with the past year. At the top, filter let users select data such as disease, location, and time period to focus on specific data. This dashboard lets users apply filter to compare disease situation For example, you can compare T disease in three separate charts. This dashboard shows T map chart. User can filter each chart separately. For example, all charts can show the same area but different disease. Before deploying the dashboard, we conducted a user testing session to gather feedback. The process includes a demonstration, group discussion, summarizing key points for development. Finally, we use the result to create a development plan. The digital disease surveillance system already gives us important information such as morbidity and mortality data. But to make disease surveillance more effective and more comprehensive, we also need to look at the other dimension. For example, event-based surveillance and risk factors. In addition to hospital patient data, we can also integrate other data sources to support disease surveillance, such as immunization data, animal health data, air quality data, meteorological data, survey data, geospatial data, new report, and social media information, and mobility data. The dataset was initially stored in cloud-based MongoDB, which posed difficulty for data manipulation and analysis. Therefore, a data engineering pipeline was established to extract the data to a local SQL environment, integrate them with additional datasets, and construct a usage-oriented data mart. This slide presents the One Health integration dashboard for leptospirosis, which combines human, animal, and environmental data to help visualize disease patterns.
So for this one, we show the vector-borne disease surveillance dashboard that we include the surveillance data and then the entomological index data and also meteorological data into one dashboard. And then we create some geoinformatics system that we include the geolocation of the patient. Let's say if we found some dengue infection patient, so we want to know that who do they live and then how and where should we do some kind of disease investigation and control. So we can create a buffer to see that. And then during the emergency situation like flooding, we integrate flood situation like the flood report and like an official report in PDF format or maybe the data from satellite into our system. We use large language model and computer vision to analyze this data and then join it, integrated it with our surveillance data, and then we create some filter that user can select like the flood that still have situation or may have the situation but is ended. In south of Thailand right now, we have catastrophic flood, very bad situation now, and then we use this surveillance data. So in this region now we see data for leptospirosis, and then we found that in Hat Yai district, specifically in Hat Yai sub-district, we never found leptospirosis before, but for this week we found at least 3 cases. So the monitoring, the chemoprophylaxis might be considered with this finding. And then we create the disease forecasting platform that let user use it like easily. They can add the season, add the trend, and then they can select the length of the data to see different between the forecasting result. And then we use the mathematical modeling to support the policy decision by identify different scenario for different intervention. Let's say we have the surveillance data in blue line, and then we trajectory if we don't have any intervention. If we have if we cancel public transport or if we cancel public transport and cancel major event, what will happen? And we use this data for policymakers to make the decision. And there are some other sources like the local news, the news that's created from EIOS, from WHO, or maybe some data from social media that might be the signal of the outbreak. So we extract this data, we use NLP and large language model to identify is there any signal of the outbreak or is just noise, and then we use this to monitor the social media, including the news. And then now when we found some signal, maybe from the digital disease surveillance that send data from hospital or maybe from any other sources, we create the notification system that push the message to the user. There are different type of user, like you need some kind of verification, this need investigation, the different may need the to monitor the trend or maybe weekly summary. And then we send it into national level, regional, provincial, and hospital level. This is some example of the dengue message that we send to the user. And then after we send the message, user can make some verification like it is eligible for the outbreak or they still verify it. And then we connect the data with the event-based system that they can let the public health officer in the field know that they need some investigation. And then when we have investigation, sometimes we do some communication with the application. So this shows some less communication of the system. I will let Dr. Supansa explain more about this.
Here are some examples of how we communicate risk. The first picture shows a dashboard of disease situation designed for easy understanding by the general public. The second picture shows an application displaying dengue risk area. The third picture shows the Line application providing information like disease prevention guidelines. And the last picture shows a summary of the top 10 diseases with the highest number of cases and deaths sent to the Line application. We also use social media to communicate risk. This is an example of how we share information through Facebook.
And then for more related to data sharing, we have some weekly or maybe daily epidemiological report that normally we did it manually. And then right now we use the large language model to generate this report, including some analysis of the situation. And then we share the raw data via application programming interface, like we share it in Thai platform, including the international platform that right now we have Thailand, Korea, and Indonesia will share in this digital information sharing platform for global disease epidemics. And when we have some data, we create some investigation. Sometimes we need some evaluation to let us know that do we are on the track. So we apply the 717 framework from CDC and from US CDC and WHO with main to with aim to detect within 7 days, notify within 1 day, and then respond within 7 days. But if we want to evaluate that, we need to review the epidemiological report. Sometimes need to do it manually. It takes time. So we also use the large language model to extract some feature like the date from the report. Sometimes it's not only one report, it's like dozens of report with dozens of pages in different format, writing by different people. So large language model is really powerful. We also extract some kind of the component that they did, and also the really important thing, what is enable or maybe what is bottleneck that creates some delay in detection, notification, or maybe response. And then when we have a lot of user, we need some kind of user support. Like we have 24-hour help desk in Line application. We have some people who working on that, and we have the manual that user can see by themselves. And then we have some kind of tutorial in YouTube, like the series of the video, and also workshop that we conduct both in person and remote via Zoom. And when we have a lot of data, it comes with very high responsibility. So we may need to think about data privacy, data security, and cyber security. We need to set up things, set up documents related to security laws to deal with that. And yep, in summary, we integrate data from multiple sources, like from our disease surveillance that we connect from the hospital and health facility via API. We connect with the event-based surveillance. We connect with the other health-related data like immunization data. We also connect with the non-health data like climate, environment, animal disease, and risk behavior. We also connect with internet-based surveillance like social media and news. And then we do data integration that we use mainly extract, transform, load by or ETL pipeline together with other technology to integrate the data. And then we do some analytics like from descriptive to predictive now, and then we connect data with the other platform and then bring us to action for disease prevention and control. The table shows summary of the technology that we use in different phases. Like in data collection, we use information technology, data engineer, data science, and AI to set up the data collection. Uh, Both of them have their own advantage. Like information technology help us to extract the data, deal with the very large amount of data on cloud, including on local environment. And then data engineer let us be able to automate the data pipeline, and then data science and AI help us to prepare, extract the value from unstructured data and do some kind of data transformation. And then when we do analysis, the data engineering help us to have the automate real-time pipeline for data analysis, including real-time dashboard that Supansar show us, and also data science and AI lets us implement the interactive and customizable data analysis that may meet the requirement of the user. We use some kind of forecasting and mathematical modeling for improve decision making and including the generative AI to interpret the result. And then when we need to raise spotlight, we need to investigate those outbreak or maybe disseminate our finding. We use both information technology that may concern about the data privacy, patient privacy, and also cyber security here. And also we use AI and data science to create some early warning, the tailor-made message for the user, and also identify the tailor target intervention, including public communication. There are some opportunity that we expanding now, like we include more environmental and occupational related diseases and non-communicable diseases. Right now, most of disease that we monitor is like infectious disease, and we add the laboratory based surveillance, including medical laboratory terminology. And then we plan to integrate into the other terminology like SNOMED and the international interoperability standard like HR75. We plan to extract the value of the valuable information from unstructured text like in clinical EHR or maybe from satellite morph on satellite image. And then we plan to implement the AI more on outbreak detection algorithm quantitative risk assessment, risk communication, and decision support. Yet we aim to change the data that we already collected into the action. How can we use that data for planning and then lastly to control the outbreak? How can we change those data into the policy decision that we used it before during the COVID-19? There are some key takeaways like we may need human-centric technology design that provide some user friendly that help them to make decision and then they can use this data to support their work. The second one is like the integrated data sources. Only clinical data or epidemiological data might not be enough. We need some kind of determinant of health behavioral data or maybe genomic data and other data to see the holistic picture of the outbreak or disease situation. We need to change the data into action and then finally into policy. We need some data analytics, modeling, and AI that be able to turn data, but not only turn it, but turn it like in timely manner that help us to detect the disease early or have the decision for policy or rapid response within uh, timely. And then lastly, we need to consider privacy, security, and governance, including the secure anonymized health data and the legal governance framework to be able to manage this data. I think at this point, Dr. Vishan may have some point to add. พี่วิชาญครับพี่วิชาญมีสไลด์แยกไหมครับหรือว่าเพิ่มตรงนี้เลยของผมน่าจะจบแล้วครับ
Thank you, Dr. Subhanet. Actually, I don't have a slide to share, but all the system Dr. Subhanet and Dr. Subhansa already shared to you. What I would like to add is I would say that as Dr. Subhanet present, the system that we show we don't mean the DDS is not the database for surveillance or disease control, but we we would let it be what we say is it's gonna be something like a actionable intelligence system. I mean, all the data in the system have to be do something for good information for the public health personnel to use it for disease control. So you can see that there are a lot of uh, uh, I mean a lot of method and a lot of process that after we get the data from the hospital, we can use it for prediction. We use it for disease control and for communicate to the people in the field. So uh, uh, I think there are a lot of ongoing process and ongoing opportunity for the system. I mean the DDS system that I have mentioned. What we have achieved right now is about the the data about the disease surveillance. Under the disease under surveillance that we use is for public health purpose. But for the next step, we are working on integrating information about the vaccination or immunization. So for the next phase of our system, we're gonna expand the disease surveillance into the immunization data. So what I just add this over.
Thank you, Dr. Vishan. So we end our presentation here. Yeah. Thank you, everyone, for listening.
Thank you, Dr. Supanath, Dr. Vichan, and then Ms. Supansa. Very interesting the way that all the three of you, like a symphony, you shared your experiences. Also showed us the real-time dashboard. We now have Dr. Palita, who is the chief epidemiologist from the Ministry of Health, Sri Lanka. Till recently, he was also leading the National Digital Health Blueprint implementation. And today he is joining us amidst stormy conditions. And then now that, since you three are actually epidemiologists, and I would like to invite his quick reflections on this because I know that he's also involved with the disease surveillance program in Sri Lanka. Dr. Palita, over to you for your quick reflections. And then we take there is a lot of questions from the audience, then we will take them. Thank you. Over to you, Dr. Palita.
Yeah, thank you, Jai, and all the Thailand team for outstanding presentation. And it's not only the presentation, but I think it's behind what they are doing for disease surveillance. I think it's very, very interesting to see that how they are doing this integrated disease surveillance with One Health approach, and from getting event-based and indicator-based surveillance into a single platform. Very interesting. And I suppose, they are doing a lot of predictions and a lot of modeling using AI and LLM. I suppose there are a lot of things we can learn from Thailand team to region, and I think AeHIN can work with them to disseminate this information going beyond presentation, and probably having some more insightful workshops or any visits. I will just give a very brief outline about the Sri Lankan context. We are also trying to develop integrated disease surveillance platform using the HIS2, and we got a lot of information from Indian integrated IDSR also. So I think South-to-South collaboration will be very much beneficial for this. I think AeHIN can be the broker for this kind of exchange of information. Thank you very much, and I'm having excellent work in Thailand. I suppose because the leptospirosis use case is very much relevant to Sri Lanka also. We are facing the same issue like in Thailand. So probably you can share the presentation with us also. Thank you.
Thank you, Dr. Palita, for joining us and then giving your reflections amidst your busy schedule and then also the prevailing weather conditions there. Dr. Vichan, Dr. Supanath and Surya, Supansa, you notice that kind of interest that comes out from the community. I think that's the value of actually having these communities of practice and then actively sharing with AeHIN. And so please, I think maybe we can take this, as Dr. Palita mentioned, from this webinar to have more bilateral discussions with them. We're also in the same region, so we could have more exchanges on this. And AeHIN will be very happy to facilitate that. Maybe we will take questions also from the audience. This was from Imran Ahmed. Can you please tell about the technology used like open source and then also tell about the event-based surveillance is to be used to other country like Pakistan? Dr. Imran, is your question answered? Because I remember seeing some slides on the technology, but if it is not, please feel free to raise your hand and then explain this more so that our speakers can actually answer to your point. And then he also asked for any link for EB surveillance. So if there is any, that could be actually shared. And then another question was, what tools were used for APIs and dashboards? This was from Dr. Alvin Marcelo from Philippines. And he also asked, is the EVO reporting system still active or has it been replaced by third era API system? Over to you, Dr. Vichan, Supanath, and Supansa.
Okay, so for the technology that we use, we use almost all of open source. Sorry, all of the software that we use, technology that we use are open sources. Like for API, we'll use less API to extract the data from the hospital. For data integrating pipeline, we use Mongo as the database, including the SQL, like PostgreSQL for the database. For ETL, we use Python with Apache Airflow to automate the pipeline. And for dashboard, for this one, we use the commercial one. We use Tableau, which is quite costly, but really easy. Actually, at first, when we create the dashboard, we try to use the freeware, the open source software, but some of them, if you need some kind of customization, it's quite difficult. Like we starting from D3, from Java, which is really nice, but you need IT specialists to be able to do that, and we have really few of them. So we change it into Tableau. With Tableau, we can train our public health officer to create the dashboard really easy. So yeah, that is only one that we use the paid license for creating our system. And then when we link with the modernized event-based surveillance, which is the very new one, now it's not like 100% linked automatically. So we need some kind of manual to link them at this time. For E0 report, I think Dr. Vishan may have more information, but right now we almost replace it with the third era of API system. Yeah. Is did I address all the question? I think
I
there are the
think so.
other question like we reach 99%. Is this because of shifting to the third period of API? Maybe yes and maybe no. At very beginning when we use like paper-based or electronic-based but not like API, we can capture the data from the hospital but not 100%. Most that we miss is like the hospital in Bangkok and also the private hospital. We can capture all of those with the API. That is the difference. And the other thing is like the primary health unit or sub-district healthcare facility. For those one, we have very low coverage during the second phase. When we change to API, we have some kind of adjustment to match with the different system, different data structure. So right now we get 99% of those. Yeah. I think not because of API, but it might related to data standardization and technology to be able to synchronize and harmonize those different standards. Yep.
Uh, Thank you, Dr. Supanat. Dr. Vichan, do you have anything to add, or I can go to other questions?
I will add that right now the API system is replaced all the traditional way of reporting system. So our hospital they don't need to key in the data for this surveillance anymore. So the API can link to our system directly. So it's kind of like the near real-time surveillance data, and the hospital really happy because they are reduce the burden of the workload of them, and also the local authority they can use their own data for decision. So I think it's a good system, and as Dr. Supansa said that the system design, we talk with many people. We talk with the people who at the field what they need and what they they want to see from our system. So this is the way we work there.
Dr. Vishan, it just reminds me. So you mentioned about like it can pull via APIs, but that's for the hospitals that already have the HIS in place. But then there may be health facilities which may not have. I remember like you mentioning previously about a month ago that you also have an online utility that is available for those health facilities that do not have an HIS in place, and then they could actually key in. And you actually brought out an important point that like apart from actually collecting this data, but those health facilities, if they get back, that's an incentive for them actually also to put the data. So I think it's a good win-win situation, like where they also get information that they need, and it will be helpful for them. So I think it's a good incentive for them. But I leave the part of the question to you. How did you deal with those hospitals which did not have a HIS in place, where your APIs won't work, right? What did you do?
Dr. Subhanet may answer on the question, but from my understanding, the API system that we developed, there are many API for many level of the hospital. For the hospital that they has the big vendor, I mean the hospital system, they talk with them and they said, is this required by the regulation that the hospital needs to report to us? So is this easy for us to communicate with the hospital that have a big system? So they're happy to do that. But for the small hospital, actually we have a technical expert in our division, in our bureau. We develop our own API. The build is on by our own, and when they request us to help, we send our expert to the hospital to install our system. What we said that system, Dr. Suman may correct me. We say is semi-offline system, right? That this system we build is up our own and let the small hospital use this system and send the data to us. And for the primary unit that they don't have like the hospital information system, we also have the web application that they need to key in to the web application.
Yep.
Thank
And yeah, actually almost healthcare facility in Thailand, they have electronic medical record or hospital information system. But the gap is with the inpatient. I think for outpatient, we have almost all, but in some healthcare facility, especially for inpatient, some of them still use the paper base. For this one, it like we need to wait them to transfer the paper into electronic health record and then sending via API. And there are a lot of hospital in Thailand with different hospital information system and different data based format or maybe data structure. So that now we need to customize our API as Dr. Vishan mentioned. And then some of them they can like connect with the API or they can build the API to send the data to us directly. But some of them cannot. So like Dr. Mishan mentioned, we need to send our staff and then we need to build some kind of like pipeline to capture the data and then the hospital can extract data from hospital information system into like the view of the database and then we put that the data that they extract into our pipeline and then we send it that what we call semi offline. Yeah, but we still use API, but just like not connect API to the database directly, but we put API somewhere and then they extract the data and then put the data into our pipeline. That it was we use.
Thank you, Dr. Supanat. Like a couple of questions, I think, from Dr. Muhammad Fadli. He's from Malaysia. How the disease group has been defined from ICD-10? Is there any group standard terminology used? And he also asked, how do you control the output of LLM and prevent them from hallucinating and taking source from the data outside of the database? So this is a question, interesting question from him.
Okay, so for the first one, actually we have list of the deceased under notification that normally they need to report this data, but we didn't use ICD-10 directly. Normally we use some kind of like definition, what kind of symptom should patient have, what kind of laboratory test should patient have to be able to meet the definition. But we use the IC10 as the proxy to tell that, oh, if you have this kind of IC10, you can send it into the system. But before sending it, you need to do some kind of verification before you sending. Let's say the system may extract this from with ICD-10, but they need to review like it is like the real case or not. Sometimes like when we need to report the rabies, for example, sometimes medical doctor give ICD-10 of the patient who are not rabies, but they have some kind of dog bite, and then they got some vaccines, and then doctor just give diagnosis as like dog bite with rabies vaccine, but the coder give ICD-10 for rabies. So this is the time that epidemiologists need to verify before sending the data to us. That's how we always call it is not real time. It's like near real time because we need epidemiologists to verify some information about that. And then, yeah, we have some standard terminology, mostly in ICD-10. But right now, the other thing is like we try to do some kind of text mining or maybe like extract the data based on keyword, not based on ICD-10. So we use some kind of patient illness or chief complaint, and then we try to compare that with the definition. Maybe use NLP or LM to do that. And the other question with large language model and how can we prevent them? Yeah, the hallucination is the problem. And we noticed that with pre-trained model there are
I
some
think
hallucination. And what we did is first thing is we do some kind of prompt engineering to control their behavior, like using the prompt to control them. First thing is like we use prompt engineering to control their behavior. The second thing is like if we have specific tasks, we do fine tuning. So let's say we want to let it extract the enable or maybe the bottleneck from the report, we do some kind of fine tuning. And then the last thing is like we use some kind of standard guideline or standard documentation to be their knowledge. And then we use retrieval augmented generation or like to control the behavior. Yeah, what is T technology that we use to control the LM behavior?
May I
thank you,
add
Dr.
may I add
Yes, please,
something?
Dr. Vishal.
May I ask something for Dr. Subhanak? So for the question about the ICD-10, actually under the regulation, I mean, and for the Communicable Disease Act, under the regulation, we require almost 70 disease that have to be reported to our system. And every year, we will look at the ICD-10 code that represent for on the disease, and then we send on the code of the ICD-10 to the hospital to review to make sure that all ICD-10 code have been sent to our system. And as Dr. Sumanat mentioned that for some disease, there are about 20 disease that we think is this serious disease or important disease. So the local staff have to be confirmed about the diagnosis of the case before sending to the system. So this is some kind of step for some specific disease that they have to confirm before sending to us. And from my understanding, I'm not the technical guy, but I talk with my colleagues, try to understand the system. But from my understanding, when the all the data come to our system, we don't use that on data for analysis. They have some technical, I mean, some technology and technical to cleansing the data before analyzing the data. So the data that we do analysis and do all kind of prediction or do kind of of evaluation, we use the data that we already cleaned. Is that right, Dr. Supansa?
Yep.
Thank you, Dr. Vichan and Supansa and Dr. Supanath. We are on top of time, so maybe we should take a group picture quickly before it's too late, and then we can wrap up. Thank you.
All right. Thank you, everyone.
Thank you. Thank you, everyone.
Thank you.
Thank you. Have a nice weekend.
Thank you.
Thank you.
Thank you.